Welcome to Exercise Science 4700 Advanced Gross Motor Assessment. I'm Dr. B, and today he's a victim. This is my victim, Nate, an honor student here at UVU. Looks like we've had some work done here, but it doesn't look like a surgical scar. It looks like a keloid. You buggered up your knee, crashing on your bicycle, and the scar went crazy.
Ropes course.
Ropes course. Oh, so the safety system failed. Not good. Anyway, teammates, today we are doing the soft tissue assessment of the knee. Having the knee is divided into 4 zones. There is an anterior zone, a medial zone, a lateral zone, and a posterior zone. As you see, I have lubricated up, liquored up my hands, and he's cleaned up as well. Both of us are negative on the COVID or any signs and symptoms, so we're going to proceed without the masks. Having already done a visual assessment, you are aware, let me have you straighten your leg out and hold it right there. Doing an isometric, with your permission, may I touch the bones and soft tissues of the knee and thigh and calf area to assess the soft tissues of the knee?
Of course.
If I do anything that makes you uncomfortable, suck it up. I mean, just... I shouldn't put that on film. Be sure and communicate, okay? I'm going to let that sit right there for a second. Having done the visual assessment, as you know, we have the quadriceps here. Again, go ahead and tighten it up. Now, the vastus medialis proceeds the most distal, whereas the vastus lateralis, not as much. You can palpate, we'll come back to that, but do a visual at first to assess that and make sure that they are their proper relationship. In a moment, I'll come back to them with the anterior palpation. I didn't know his knees, and you just noticed first thing, I did pick up a scar, and recognizing the type of scar and getting some history. And did that leave you with any internal damage or change in function in your knee? Do you have any pain with it at this point? And a keloid is a scar that's just gone out of control. And there's a lot of theories and different modalities to try to protect that. Having said that, again, reviewing the visual and what it should look like, now we're going to go to the anterior zone. We want the person sitting on the table with the legs both dangling off initially. So go ahead and drop those legs if you would. Slide back so that your knees are up against the table and they are dangling. Eventually, we will put them up on our lap. We're going to start with the anterior zone. Actually, I'm going to put it on the chair to begin with. I have better control there, and it puts it up at eye level. With the anterior zone, we're going to start out like we did with bony palpation, orienting with our hands around the heads of the gastrocs and on the joint line. With that, we're going to go up and palpate the vastus medialis and up into the girth of the quads. And Hoppenfield says to palpate them bilaterally at the same time, and that works as well. But I'm just doing this to isolate down. Go ahead and relax the leg. It feels like this is working. There we go. Vastus medialis. Vastus lateralis descends down further, and I want him relaxed, otherwise the tissues are going to push me further away. The vastus lateralis, rectus femoris, and vastus intermedius from here on up, and the vastus medialis all wrap up in the same fascia. So once you're past these 2 spots, you cannot distinguish one from the other. So it's just the major girth of the quads, any tenderness elicited in there, and milking down through. The quads actually tie into, pass over the patella on the proximal or superior aspect and the medial border, come down and become the infrapatellar tendon. It's a continuation of the fascia sheath down onto the tibial tuberosity. Some people will consider it a ligament because it does tie into the patella to a degree, and from bone to bone is considered a ligament. However, the quads continue on over, and muscle to bone, which it is also, is a tendon. Hoppenfield refers to it as the infrapatellar tendon. So, orienting here, we're going to palpate the borders of that patella where the soft tissues tie in, and then isolate that infrapatellar tendon. While on that infrapatellar tendon, we have passed over but didn't notice some other soft tissues. Specifically on the anterior aspect of the patella, we have the prepatellar bursa. 4 significant bursa soft tissues in the anterior knee. 3 in the anterior, 1 in the anteromedial. Prepatellar bursa, and if it becomes boggy or irritated, we call it housemaid's knee. Usually because when you kneel down, truly you kneel on the tibial tuberosity. But if you happen to be rocking way forward, you roll over onto the patella, and that bursa becomes irritated, like a housemaid rolling way over, reaching far, scrubbing floors. Housemaid's knee. You cannot distinguish it, but anterior on the infrapatellar tendon is the superficial infrapatellar bursa. You shouldn't feel anything unless it's pathologic, and then again it would be boggy, and you'd go for, it's usually a traumatic blow, a compression or contusion type mechanism. Deep to that, around the sides you step off, and right in the joint line we are on the infrapatellar fat pad. You cannot really distinguish it, it's just soft in there. But going down the length and to the sides, you should not feel anything, and that is the deep infrapatellar bursa. Prepatellar bursa, superficial infrapatellar, and deep infrapatellar. Right now I will go to the pes anserine from the tibial plateau, slightly anteromedial, you step off into this flare. We have a group of muscles that come right here. We will identify them with the medial zone, but talking about bursa, I'll go ahead and go there. And you cannot distinguish it, but it's just inferior to the flare of the anteromedial tibial plateau, and we have a pes anserine bursa right there. To reduce the friction, it is deep to those 3 tendons that come together and make up the pes anserine. Coming back up to the joint line, palpating the joint line, deep, we're on the infrapatellar pad, but deep in the joint line, here I am on the medial meniscus. The medial meniscus actually ties to the tibial plateau with coronary ligaments. And medially, it ties in to the medial collateral ligament, which is actually not its own ligament, it's just a thickening of the medial capsule of the knee. So medial meniscus, and if you ever elicit pain right there, it's usually the meniscus. You can make the meniscus stand out by turning, you remember this, that this one will stand out if you turn the toes the direction of it, and then it disappears under your fingers again. So I'm going in, and then it pushes me out a little bit by rotating the tibia. It is not as mobile as the lateral meniscus is. We'll talk about that in a moment. Coming around medial in the joint line, you cannot distinguish the capsule, but off of the medial epicondyle, or the most prominent part of the medial femoral condyle, down to the tibial plateau, you are on the medial collateral ligament, another soft tissue. A portion of it ties right into the meniscus, and a portion ties in to the tibial plateau. So if you happen to have a valgus stress, creating a valgus at the knee, it will stress this medial collateral ligament. And I'm ahead of myself because that's on the medial zone. But the medial collateral ligament, and since it ties into the medial meniscus, if it's grade 1, 2, 3 sprain, it may take out the meniscus and yank it, tear it. And once it's torn, the knee is far more unstable, therefore the anterior cruciate will often go with all of this mechanism here. That's called an unhappy triad. You take out the medial collateral ligament, the medial meniscus, and the anterior cruciate. Or you can take out the cruciate and the meniscus and the collateral, or you can take out the meniscus and one of the other 2. Either case, unhappy triad. Still anterior, on the lateral side, let's go here, lateral side of the joint line, when you push into that indentation there, it's soft, and that is the lateral meniscus. It is more mobile, it's more dynamic. When we do certain muscle movements, the popliteus muscle, small muscle in the back of the knee, attaches to the femur, medial posterior femoral condyle, and down to, did I get that proximal attachment right, if you remember right? And it ties on to the medial meniscus, posterior aspect. It pulls on that meniscus and changes its shape while this femoral condyle moves around on the tibial plateau and makes it more dynamic. Because it's more mobile, it usually is able to give and take with movements of the knee, so it's not as likely to be injured. The most common meniscus torn is the medial meniscus, and it's a closed kinetic chain pivot of the knee, rotation of the knee. We do have 10 degrees with the screw home mechanism, but a pivot mechanism of the femoral condyles grinding in that dish of the meniscus that tears the meniscus. Anterior aspect of the knee. Let's go to let me back up. We have a condition called Osgood-Schlatter's disease. Going through puberty, young men and women, but men because of more testosterone being prominent, the quads are developing so rapidly, there's a lot of stress on the infrapatellar tendon right on its attachment on the tibial tuberosity. That becomes irritated, so at the attachment where tendon ties into bone and it's irritated, bone will suspect injury, so it'll start to lay down more bone as it remodels, and this becomes prominent and tender. Bits of bone may migrate up into the tendon. This is leading to myositis ossificans above and beyond this class. But anyway, it becomes irritated here and very inflamed, called Osgood-Schlatter's disease. With mine, because my quads were so massive at puberty, they smile knowingly. I had joint pain. That was my first experience with a physical therapist. 8th grade, sitting on the football field, Little League football practice, I had this joint pain. I can remember the assistant coach testing my knee. His profession is a physical therapist. And he tested it and looked at his brother, the coach, and said, I think he's got Osgood-Schlatter's. Took it to the doctor. Sure enough, that's what I had. But the quads, as I inferred earlier, it was a lie, being so massive, rather than irritating the distal attachment, I had an avulsion fracture. The quads remained intact and pulled the tibial tuberosity 3/4 off of the tibia. So they put me in a plaster cast for 4 months from here to here. That's another story. My niece was diagnosed with it years later, and they said to her, oh, don't run up the stairs and don't stand up on the pedals to sprint your bicycle. Don't use your quads too much. And that's all they did. So there's a wide variety. Another story. Osgood-Schlatter's. From an overuse condition, we will get patellar tendinitis, inflammation of the infrapatellar tendon. We use the TPT test. One is a history. I hurt. Where? Right around here. May I touch your knee? Yes. Is that it? Just like the epicondylitis, lateral and medial. Here we can go here. Yep, that's the spot. That's the tendon pressure test for jumper's knee. Let's go to the medial aspect of the knee for an assessment. Now I like to have it between my legs here to control the leg. We're going to have the medial meniscus. We've already palpated the medial collateral ligament, but you cannot distinguish it. We lose the meniscus as the joint lines come together between the tibial plateau and the medial femoral condyle. From here, we've already done the vastus medialis. I'm going to have you pull your heel back into my hand. That makes a tendon stand out. It is the most posterior and prominent. Right there. You can actually grab it and relax. That is the semi-tendinosis of the hamstrings. You can palpate that tendon quite a ways up the hamstrings, and then they all become one large muscle group, which proximally tie onto the ischial tuberosity and the proximal neck of the femur. Semi-tendinosis, moving medial and anterior. You have a soft tissue belly here, kind of like I won't use the band because the band is here. And I've noticed with this, the other leg, no, the band is here. Okay, so it becomes more of a muscle belly right here that you can mobilize. That is the gracilis, the medialmost muscle of the thigh, and subcutaneous, the gracilis. Between this tendon and that muscle belly, you can actually insert your fingers between the two, relaxing your leg and going deep. There, I feel a muscle belly. It's another soft tissue, but it's not the gracilis, and it's not the tendon of the tendinosis. Deep between the two, another muscle belly. That is the semimembranosus. It's more membranous. It ties into the posterior aspect of the tibia, whereas the tendinosis, you can palpate it coming on around. It disappears into soft tissue. The gracilis, and now I'll have you flex your knee again and maybe pull it back a little bit. Can't see it very well, but coming superficial to the rectus femoris and the vastus medialis, we have the sartorius muscle, ASIS, down across. Find the joint line and relax. Joint line, just inferior, the anteromedial flare of the tibia. Those three tendons, the sartorius, the gracilis, and the semitendinosus, all three come and tie in right here. All three pass posterior to a medial lateral axis of the knee, so they are flexors. You can make the gracilis stand out a little bit if you'll pull your heel in and turn your toes in a little bit. Does make that gracilis stand out even more because it's got the best. There you can see it. Go ahead and do it again, and I resist. You can see it start to stand out here because it's got the best mechanical advantage to do an internal rotation of the tibia on the femur. Semitendinosus, gracilis, between the two, semimembranosus, sartorius. We've done the medial collateral ligament and the medial meniscus. These three come down, sartorius, semitendinosus, and gracilis make up pes anserine, and we have a pes anserine bursa. This is the soft tissues on the medial aspect of the thigh. Now we'll go to the lateral aspect of the knee, and we did the meniscus on this side, orienting again with your thumb in the joint line, travel laterally till the joint line disappears. Proceed proximal, and more prominent than the medial side, we have the lateral femoral epicondyle of the lateral femoral condyle. From there, you've already learned how to find, there's the joint line, the head of the fibula, right here, very prominent. The lateral collateral ligament runs from the lateral epicondyle to the head of the fibula. Unlike just a thickening of the medial capsule for the medial collateral ligament, the lateral collateral ligament is its own independent ligament, independent of the capsule. We got crepitation going on in there. You suffer from SMB, don't you? So many birthdays. Your knee is creaking. Okay. See, I am listening even though I'm listening over here too. From here to here, medial epicondyle, prominent bony landmark, head of the fibula. If you'll put this ankle bone across this thigh, please. That makes it stand out so that if you'll, very prominent on him, head of the fibula, lateral epicondyle, right there you can roll that pencil. Can you feel that? That is the lateral collateral ligament. Another soft tissue. It's neat to learn these little things that make different structures stand out. From there, proceed distal to the head of the fibula and step just off. Hoppenfield infers that you can feel it. My experience, no, but I can aggravate it. The common perineal nerve. just inferior to the head of the fibula. We want to be careful with this one because it is very subcutaneous, relatively like the ulnar nerve. Had a track athlete take a blow to his knee one season at another university, and came in, it was acute, so the athletic trainer student is pricing it. But this student does not communicate to the change in shift. Another trainer comes in before the up to 20 minutes of ice is done. So there was no transition over. You watch nurses in a hospital do a change in shift and they go to each patient and report. There should have been a report between the early and the later student trainer. Didn't happen, so this athlete sat here for 2 to 3 hours with the ice on his knee, directly on that common peroneal nerve. Well, it took the nerve out and it ended his track season. Wow! Significant. So their health is in our hands and we need to communicate and be conscious of that. Lateral collateral ligament, Hoppenfield says, like the annular ligament here, you can feel it, but I've not, but you can aggravate it. In special tests, that is a location we can do the Tinel sign. Got him. That time I aggravated it. Lateral collateral ligament and common peroneal nerve. We also have the iliotibial band, tensor fascia latae, from the ASIS region up here. It's a debate whether it's a hip flexor or an abductor, but it becomes a fascia band. This is not a tendon, it is not a ligament, it's a fascia, a thickened fascia. Comes across and helps stabilize this very vulnerable, largest joint of the knee, most of the body, most vulnerable joint because it's simply a hinge joint, not much bony structure. So we have collaterals to help and meniscus to help and hams and quads over here, quads and collaterals, and laterally we also have the iliotibial band. If you'll straighten the leg out please and just suspend it up off the table. There you go. That makes it stand out right there. Versus the ligament, here's the head of the fibula, so the ligament is clear down here. This iliotibial band on this fine specimen of man, hold your leg up in the air and even suspend it up off. There is vastus lateralis, but here comes the iliotibial band. Comes around and ties onto the proximal, relax, anterolateral tibial tubercle. Wow. Proximal anterolateral tibia, just under the flare. With bony tissue, we learned that while this becomes a flare underneath here with the pes anserine, on this side there's a bit of a knob. There's more bony tissue there. It is a landmark, the proximal anterolateral tibial tubercle, and a ligament actually runs between it and the head of the fibula, right there. Not distinguishable, very seldom involved in any pathology, unless you do a Brett Boyer a year ago May, and as a part of your double dislocate, triple fracture, torn meniscus, you, in order to dislocate the fibula off of the tibia by way of the interosseous membrane, you had to rupture that ligament as well. Who'd have thunk? Anyway, it all came back together well. I was in good hands. The anterolateral tibial fibular ligament, I don't know. There's a ligament right there. Let's find it here real quick. Pes anserine, that's medial. Let's go lateral. And it is called the, silly me, lateral collateral, anterior superior tibiofibular ligament. Lies in the crevice between the tibia and the fibular head. Seldom is it involved. Okay, lateral, tensor iliotibial band, collateral ligament. That ligament, relax. Now pull your heel into my hand again. makes another tendon stand out, biceps femoris, not biceps brachii, biceps, 2 heads, femur. One head crosses the hip, one head does not. This is the tendon, like the semitendinosus of the biceps femoris. And relax. That you can palpate all the way down, and it too attaches on the head of the fibula. Subcutaneous, it's real nice that it's right there, and you can feel its attachment all the way down, along with the lateral collateral ligament. And palpate it up into the belly of the muscle. From there, we're going to the posterior aspect of the leg. Orient with your thumbs on the joint line, and your fingers are grasping the lateral head of the gastrocs and the medial head of the gastrocs. They do cross the knee and attach on the posterior aspect of the femoral condyles. That makes them behind a medial lateral axis, so they are a knee flexor, the heads of the gastrocs. The soleus doesn't start till down on the tibia, so it does not cross the knee. The heads of the gastrocs engulfed in a fascia, so when you look at somebody's knee locked out and maybe an isometric of slight flexion, you can see the heads of the gastrocs, but you don't really distinguish. Let me back up and say if there's a strain of the quads, it's usually just immediately proximal to the patella in the rectus femoris or the vastus intermedius. Thank you, teammate. So that's my ADD going all over the place. Heads of the gastrocs, and you can palpate both and work on down the belly of the muscle. Sometimes the muscle comes down, the 2 heads, and becomes a common tendon here. I remember dancing with some of the gals with the dance team I was on, and they were real upset. My partner happened to have cankles, meaning she didn't have the nice skinny little thing here. The heads of her gastrocs came clear down to here, so it looked like fat ankles. They weren't so nice in the stilettos. And relax. But you can palpate the length of that, becomes the triceps suri, etc. The lateral border of the posterior aspect of the knee is the biceps femoris. The medial border is the semitendinosus. Their muscle bellies tie together, not becoming one, but they make the roof up here, and the floor, most distal aspect of this triangle, is the heads of the gastrocs. Some soft tissues we have in here. At the inguinal ligament, we had navigate, nerve, artery, vein. Well, behind the knee, we have those 3 structures again, but the most superficial is the nerve, and then we have the vein, and then the artery, NVA. And that jumped out to me because when I was a youngster in the late 60s, early 70s, the Vietnam War was going on. You got a report every night about the NVA. NVA is the North Vietnamese Army. So when I heard NVA here, I think that's my acronym, North Vietnamese Army. I'm not saying good or bad, I'm saying that's what it's called, okay? You really don't feel them very well. You might feel a cord back there, and that's the most superficial, most posterior. That is the popliteal nerve. And then deep to that, moving anterior, can't feel it, V, the popliteal vein, and then the popliteal artery, okay? And on occasion, you may feel a boggy bag back in there. If you do, it is not normal. It is called Baker's cyst. It's actually a herniation and filling with fluid of the fascia of the 2 heads of the gastrocs. Sometimes it can be a herniation of the posterior capsule. People still argue about that. Doesn't matter. Its treatment's the same, okay? And it has nothing to do with the support and integrity of the knee. These are the soft tissues of the knee: anterior zone, medial, lateral, and posterior. Thanks for your attention, and thanks for your patience. Appreciate it.